Hello friends, today we are going to learn about stop and chop technique of phacoemulsification in nuclear sclerosis grade 2 cataract. Usually we make a side port incision at 3 and 9 o'clock position, but here I made one at 10 o'clock and one at 3 o'clock position as there was a pterygium. Now we are injecting the air bubble and injecting the dye to stain the entire capsule. We injected air bubble to protect cornea from the staining. Before making the main port incision, we made the anterior chamber adequately form. I am using 2.8 keratome to make main port incision. The length of main port incision is around 1.8 to 2 mm in length and 2.8 mm in width. Now before doing capsular access, I remove all the air bubble and make the anterior chamber well formed. I am using 26 gauge cystitome to make the capsular access. We make the 26 gauge needle at 45 angulation to make the cystitome. With the left hand, I am remaking the eyeball at a primary position. Slow movements and just 1 to 2 clock hours of movement of anterior capsule. No pressing over the side port incision. After making capsular access, we remove little bit of viscoelastic from the anterior chamber. Now we are doing hydrodissection. At 3 and 9 o'clock position, we can see a nice fluid wave passing behind the lens. Now surgeon is tapping the nucleus from the other side hydrodissection. Nucleus is now little bit prolapse, so I am trying to make it push inside the bag. Now rotation of the nucleus. Nucleus rotated very well. I am using sense key to rotate the nucleus. Now before doing sculpting, I am removing anterior cortical material with a phaco probe. Now in the center, trenching. The depth of the trench should be adequate. Trench should not be too deep, otherwise there are chances to punch the posterior capsule with the phaco probe, and not too shallow, otherwise the nucleus will not get separated. Now I am doing chopping in the one heminucleus. During chopping, we have to bury the phaco probe tip at the middle of the nucleus, first with a little bit of power and holding the nucleus with vacuum. Here the surgeon is removing the piece of nucleus so that there becomes a space to rotate the other heminucleus in the bag. Again burying of the tip and chopper movement in front of the phaco probe. During quadrant removal, your phaco probe should remain in the center position, central 4 mm area. We have to check for the separation before doing quadrant removal. Otherwise, the nucleus, entire heminucleus will come in the anterior chamber. We have to use our left instrument to feed the phaco probe tip. As we can see, some nuclear species are rotating inside the eye. We are using just vacuum and little bit of power. Now there is a epinuclear shade. I go into the epinucleus mode and remove the epinuclear sheet with vacuum. There is no power in epinucleus mode. Now the cortical matter is remaining. We are removing cortical matter with bimanual irrigation aspiration cannula. We go into the periphery and give little vacuum. Then as the cortical chunk comes into center, we give more vacuum. In this manner, the one half of the cortical matter is removed with this manner. Be cautious not to catch the posterior capsule in this mode. Now surgeon switch the hands, irrigation cannula in right hand and aspiration in left hand, removing sheets of the cortical matter. Don't try to pull small fibers but big chunk of the cortical matter, as there are higher chances of PC rent during small fiber removal. Now I am filling the bag and anterior chamber with viscoelastic and IOL implantation step. I am not inserting IOL injector fully inside the anterior chamber, but my tip is just inside the anterior chamber through the main port. Reading haptic went inside the bag, optic went inside the bag, and now giving more viscoelastic. With the since key through the side port, I am just dialing the IOL downwards and inwards. So the trailing haptic also went inside the bag. Now I am removing remaining viscoelastic with a coaxial probe. It is important to aspirate viscoelastic as it can cause inflammation in the postoperative period. Now hydrating the side ports and the main port incisions. Wall of the main port incision is being hydrated and the roof of main port incision. It is important to check the pressure of the eye. Even after removing the speculum, we have to check whether the pressure is adequate.